What I wanted to do today is really just start out with an overview of bundle payment methodologies, and then we'll quickly get into our panel discussions where we'll hear about some practical applications of them. So we want to talk about bundle payments. What are they? We'll talk about some common design themes that exist in some current methodologies, and we'll look at the structure of just a few existing models. And again, you can find a lot more detail in the report that was just recently published Friday, so I'll cover a few of the existing methodologies, but less detail than is provided in that report, and also additional methodologies in that report. So a bundle payment, and let me just read this here, is a method of reimbursing a provider, or in many cases a group of providers, for the provision of multiple healthcare services that are associated with some episode of care under a single fee or a payment. So what does that mean? Basically, it's a change in the concept from the fee-for-service delivery method, where all the individual healthcare services are provided and paid for separately, toward a more integrated delivery approach and a more integrated payment methodology. The episodes that we're talking about can either be acute in nature, like a surgical procedure to fix some problem, or they can be chronic, like an ongoing disease such as asthma or diabetes. And the episode or the bundle includes all of the related services for the episode, such as the hospital admission, if there is one, any related ambulatory care, pre- and post-discharge and follow-up care, even pharmacy costs in some cases. In the case of the acute conditions, is generally a time period which generally covers a pre- and post-surgery period, so maybe 30 days pre, 60 days post-surgery. For the chronic conditions, it's usually a time period of about a year, so what it takes to care for a patient with asthma for a period of 1 year. Some of the more common bundles you can see here include, that are listed here, the acute and chronic conditions, total knee replacements, surgeries, and as I said, chronic conditions like asthma and diabetes. So for those of us that are a little more visually oriented, this just depicts the concept and how it differs from the fee-for-service model. In the traditional fee-for-service model, a payer makes payments to as many individual providers who are involved in treating a patient, even for a patient's single acute care episode or an ongoing chronic condition, and each provider is then billing and receiving payment separately for those services. One example of a bundle payment model is that payer is making one payment to a single coordinating provider for all services that the patient's receiving from the multiple providers, and the payments are then distributed among those providers accordingly. Although the payment flow doesn't necessarily have to happen in this way, and I think we'll hear some about that from our panelists. There's also some models that are sort of in between these two. Some retrospective models pay in a fee-for-service manner for an episode, and then there's a reconciliation done at the end of the process, either at the end of the year or at the end of the episode. And that reconciliation is then based on a predefined case rate versus the actual spend, and then maybe explicitly some quality factors as well. And we'll see how that might work a bit later. There's some common themes in some of the existing bundled payment methodologies, typically designed to achieve multiple goals: better coordinated and higher quality care at eventually a lower cost. Costs are lower in theory because the adverse events are reduced or minimized. Providers might be explicitly or implicitly rewarded, and most often it's rewarded for quality. So they're explicitly rewarded for quality through the actual bonus payments that might occur for meeting certain quality thresholds, and that's built into some of the models. And they're implicitly rewarded for quality for being able to retain more of the funds that are paid by reducing readmissions and other adverse events. The bundles can be designed prospectively, where the provider group might receive full payment in advance at a set fee, or retrospectively, where the claims are paid sort of on a fee-for-service basis, and the cost for the bundled service is then reconciled at the end against a total cost target for the bundle. In theory, bundles might be easier to implement in a fully integrated system and used simply as one of the payment tools in that system, but they can also work in less integrated systems, and I think we'll hear more about that from our panelists. And as we said, they can be designed around either acute or chronic episodes. Various groups have been involved in designing bundled payment methodologies and are piloting those models. A few that I'll talk about in a minute include the Prometheus payment model, the Minnesota Baskets of Care, and the Geisinger's model that they started out with cardiac bypass surgery in their additional newly defined conditions. Generally, the way that all of these models work is that the models determine what specific services should be included in the bundle. And that's based typically on clinical guidelines, treatment protocols, and in some cases, extensive consultation then with providers and other people in the process. To arrive at what services should be included in that bundle that represents sort of the best practices model with a delivery with optimal outcomes.